Now we'll be discussing CTEV, which is congenital talipes equinovarus. So first, starting with the incidence. So it occurs in 1:1000 live births, in 1 per every 1000 live births. So relevant anatomy. So first you need to know the relevant anatomy. So first, in the foot, we have these joints. So the ankle joint between the tibia and the talus, okay? And then the subtalar joint. So here you have the ankle joint between the tibia and the talus. The subtalar joint, that is below the talus, between the talus and the calcaneum. The talonavicular or the TN joint, and the calcaneocuboid joint or the CC joint, okay? Talus, navicular and cuneiform, and here you have calcaneum and cuboid, okay? So you can also divide the foot into forefoot, midfoot and hindfoot. So hindfoot, so it comprises of the subtalar joint, okay? Midfoot comprises of the talonavicular, the calcaneocuboid, so TN, CC, as well as the NC, so navicular cuneiform joints. Then the forefoot is cuneiform metatarsal and other joints beyond it. So you also have certain ligaments related to the etiology. So you have deltoid ligament. So it is the MCL, medial collateral ligament of the ankle with superficial and deep components. So spring ligament, it joins the anterior end of the calcaneum to the navicular. Okay, so calcaneum to the navicular. Okay, so there you go. And then you have interosseous ligament between the talus and the calcaneum, so between the two bones. Then the capsular ligament, so here we said like TN, then NC, then cuneiform metatarsal, right? So all these joints, they have capsular ligaments. They're important structures in the pathology. And then plantar ligaments, they extend from the plantar surface of the calcaneum to the foot, giving rise to the longitudinal arch of the foot. Then you also have certain tendons related to the pathology of clubfoot. So they are on the medial side of the foot. So you can remember it as Tom, Dick and Harry. So tibialis posterior T, Dick, so digitorum, so flexor digitorum longus, and Harry, so flexor hallucis longus. Okay, so tibialis posterior tendon has its main insertion on the navicular, and it is the most important muscle related to the pathology of clubfoot. Then you have certain nomenclatures. So first, equinus. Equinus is the foot is flexed in plantar flexion, okay? And then calcaneus, the foot is fixed in dorsiflexion, okay? So this is calcaneus, this is equinus. Next you have varus, which is the foot is inverted and adducted at the mid-tarsal joint, so it faces inwards. And then valgus, everted and abducted, so it faces outwards. Cavus, so the longitudinal arch, especially the medial longitudinal arch of the foot is exaggerated, so it goes like this, okay? It is cavus. And planus is when the arch is flattened, and splays when the transverse arch is flattened. So you can draw these diagrams. Equinus, okay, plantar flexion deformity. Calcaneus, it is dorsiflexion deformity. Varus, inwards. Valgus, outwards. Cavus, exaggeration of the longitudinal arch. Planus, diminution of the arch. And splay, transverse arch flattening. Next, etiology. So in the vast majority of cases, the etiology is not known, so it is idiopathic. In others, you have certain conditions like oligohydramnios and breach, etc. And some underlying causes in secondary clubfoot, such as AMC, so arthrogryposis multiplex congenita. So there is fibrosis of the structures. So conditions like that can also be found. So idiopathic clubfoot, you have certain theories. So first is the mechanical theory. So the raised intrauterine pressure forces the foot against the wall of the uterus in the position of the deformity, which you find after birth. So then ischemic theory. So ischemia of the calf muscles during intrauterine life results in contractures leading to foot deformities. So you can have mechanical theory wherein the foot is is pushed against the bladder wall, resulting in the deformity. Ischemia of the calf muscles resulting in fibrosis and then the deformity. And then genetic theory also. And in secondary clubfoot, you have certain neurogenic disorders. So there is a neuromuscular imbalance. So the inverters and the plantar flexors are stronger than the everters and the dorsiflexors. So that is why there is an equinovarus deformity. This occurs in paralytic disorders such as cerebral palsy, polio, spina bifida, myelodysplasia, and Friedreich's ataxia. You also have AMC, so arthrogryposis multiplex congenita. So it is a disorder of defective development of the muscles and they are fibrotic. So this results in deformities. Then moving on to the anatomy. So all the tissues, the bones, the joints, ligaments and the muscles have a developmental abnormality. So starting with the bones of the foot are smaller than normal in CTV. They're smaller. So the neck of the talus is angulated so that the head of the talus faces downwards and medially. Okay, so the neck is angulated. Okay, so that it is angulated so that it faces downwards and medially like this. Okay, so that the foot goes like this, downwards and medially. Next, calcaneum is small and concave medially. So both the bones are small and face medially and downwards. Next, joints. So you have this mnemonic. So cave. So cavus deformity. It occurs at the it occurs due to excessive arching of the foot at the mid-tarsal joints. Then adduction. It occurs at the mid-tarsal joints again. Then varus. So varus or inversion. It occurs primarily at the subtalar joint. Okay, that is why your talus, as I talked here, it is moving downwards and medially, inversion. And then equinus. It occurs at the ankle joint. So mid-tarsal, subtalar, and ankle joint. So CAVE. Next, muscles and tendons. So moving on to the muscles. So posteriorly you have the Achilles tendon. That is there. That's it. Then medially again Tom, Dick and Harry. Tibialis posterior, FDL and FHL. And then capsule and the ligaments. So posteriorly you have the posterior capsule of the ankle joint, posterior capsule of the subtalar joint. So here you have tibia and the talus, and then talus and the calcaneum. So both these joints. And then you also have the posterior talofibular and calcaneofibular ligaments. So PTF and PCF ligaments. Medially, you have the spring ligament, deltoid ligament, and the TN, so talonavicular ligament. Okay. Plantar, you have the plantar fascia and the ligaments, and others you also have the interosseous ligament between the talus and the calcaneum. The skin develops adaptive shortening on the medial side of the sole. So there are deep creases on the medial and the posterior side. There are dimples on the lateral aspect of the ankle and midfoot. So deep creases on the medial side, dimples on the lateral side. Next, secondary changes, they occur if the foot in the foot if the child starts walking on the deformed feet. So callosis and bursae develop over the bony prominences on the lateral side of the foot. So clinical features. So basically it can be detected at birth. So at times the deformity is very mild, so it is called postural equinovarus. The patient can be brought during early infancy. So when the delivery is conducted at a PHC, then the child is referred after 3 to 6 weeks. Then the child can be brought during late infancy and early childhood. So he has received treatment elsewhere, or the deformity has recurred, or it has never been corrected. Then the children can also be brought during late childhood, and ignorance, poverty, illiteracy are the reasons for such late presentations. So in examination, you basically do a screening test, which is dorsiflexion. Normally, you can dorsiflex the foot till it touches the shin of the tibia in a normal newborn child. But in CTEV, this is not possible. Okay, you also have certain classical findings in CTEV. First, it is bilateral. So there is a bilateral foot deformity in 60% of the cases. Then the size of the foot is smaller. I told you about the smaller bones. Okay, in unilateral cases, the size of the foot is smaller. The foot is in CAVE, right? So A, V, E are early findings and C is a late finding. Okay, next, the heel is small in size, the foot is small in size, there's a CAVE deformity. Next, there are deep skin creases on the back of the heel and the medial side of the sole. Bony prominences on the lateral side of the foot. Okay, and outer side of the foot is gently convex. Okay, so because it is like this, the outer part is gently convex. On attempted correction, one can feel the tight structures posteriorly, tendo Achilles and the plantar warts, the plantar fascia. Okay, so you have certain terminologies. That is, if it is supple, then the foot can be brought to the normal position. It is supple, it is nice. If it is rigid, the foot deformities are not correctable. If it is resistant, that means you have tried to correct it to with manipulation and POP casting, but they are resistant to that manipulation. Neglected, not treated for 1 year, relapsed, got corrected but recurred again. Okay, so a patient with residual polio, 1DD is polio. So with polio also, the patient can present with equinovarus deformity, which might mimic CTEV, but there will be paralysis of some other part of the limb. Okay, and then if there is sensory deficit, it points to an underlying neurological cause. And then deformities at the other joints indicate possible AMC. So you have to differentiate between primary and secondary clubfoot because the prognosis is different for both. So if it is present since birth, bilaterally present, it is primary. Unilaterally present, it is secondary. So foot size is much smaller in primary it is normal in secondary. Heel size is also smaller in primary with lots of fat, so that is why you cannot feel the calcaneum. That is why the calcaneum may be felt with great difficulty, whereas it is normal in case of secondary club foot. So foot size and heel size is smaller in primary, normal in secondary, and it is bilateral in primary, unilateral in secondary. Skin is chubby again because fat is present. And in secondary you have AMC, right? So atrophy and fibrosis, so it is atrophic. Neurological examination is normal in primary, but you can have sensory and other deficits, neurological deficits in secondary clubfoot. Prognosis is good in primary, poor in secondary. So diagnosis, you do X-ray of the foot. So in whichever position, so the talocalcaneal angles which are there, the normal is 35 degrees, but in both AP and lateral views, in CTEV they are reduced. Okay, normal is 35, in CTEV they are reduced. So treatment, basically what do you do? So first you have certain non-operative methods such as manipulation alone. So what you tell the mother is, you tell the mother to dorsiflex and evert the foot. Okay, it is like this, you dorsiflex and evert the foot. Okay, dorsiflexion just like the screening test, and then tell her to apply such pressure that her own fingers are blanched. That much pressure should be applied. Okay, this pressure should be maintained for 5 seconds and repeated several times over a period of 5 minutes. Mild deformities or minor deformities are corrected like this. For major deformities, you have to use manipulation and POP. So first, sedate the child and try to manipulate the foot. So presently we use Ponseti philosophy. Earlier it was kites. So in Ponseti philosophy, what you do is you manipulate it and then put a cast over it. So what you do is CNC. So the cuboid navicular complex. So the CNC is adducted under the plantar flexed talus. That's it. CNC is adducted under the plantar flexed talus. So cuboid navicular complex, the 4-foot complex. Okay. So that is adducted. CNC is adducted under the plantar flexed talus. Okay. So you basically put thumb pressure over the talus head in Ponseti's method, and not over the CC joint, so not over the calcaneocuboid joint as in kites method. In kites, KCC, okay? You put pressure with the thumb over the talus head in Ponseti's philosophy. Treatment is started within first week of life, okay? First, the cavus aspect of the deformity is corrected. First, C is corrected, then AVE. Okay, this is the order. Okay, after every manipulation, you put an above the knee POP cast, okay, which is changed every 5 to 7 days. So every 1 week you change it. So within 6 weeks, it is possible to correct all the aspects of the deformity. So the equinus component often remains under-corrected because it is the last component which you corrected, right? So it is treated by percutaneous tenotomy of the tendo-Achilles. Next, you have certain operative methods. See, even with the remarkable success with Ponseti method, you still have to consider serial casting if before considering surgery. Okay. So in more severe deformities which are not corrected by conservative methods, operative treatment is required. So in children younger than 3 years, soft tissue release may be sufficient, but bony operations are required in older children. So first, starting with posterior medial soft tissue release, so PMSTR. So you release the tight soft tissue structures on the posterior and the medial side of the foot. So on the posterior side, what do you do? So you lengthen the tendo-Achilles by doing a Z-plasty. Okay, so go like this, bring it down and lengthen the tendo-Achilles so that you correct the deformity. Next, release the posterior capsules of the ankle and the subtalar joints. So here, ankle and subtalar joints, just release the posterior capsule so that, if you release the capsules, again, you can bring down the foot. And then you can also release the posterior talofibular and calcaneofibular ligaments. So the ligaments which are going till the fibula, okay, just bring them down, also release them so that the foot is corrected. On the medial side, again, you have Tom, Dick and Harry. So lengthen these 3 tendons, release the 3 ligaments. So you have the deltoid ligament, the superficial part of the deltoid ligament, spring ligament and the TN, okay. Release these 3 ligaments medially and release 3 more structures in severe cases. So you have the interosseous talocalcaneal ligament and the navicular cuneiform. So the talocalcaneal, the navicular cuneiform and the cuneiform first metatarsal joints only in severe cases. Otherwise, Tom, Dick and Harry, and deltoid spring and TN on the medial side. On the plantar side, do a plantar fascia release and also release the short flexors of the toes. You have flexor digitorum brevis and abductor hallucis from their origin on the calcaneum. Okay. So you can also do a limited soft tissue release. So the foot remains partially corrected after conservative treatment and only limited release may be sufficient. So for example, if there is equinus alone, you can do a posterior release. For adduction alone, you can do a medial release. For cavus alone, you can do a plantar release. So you can also do tendon transfers. So transfer the tibialis anterior to the outer side of the foot as it acts as an everter, because tibialis anterior and posterior both are inverters of the foot. They cause the deformity. So what you do, you take one muscle, tibialis anterior, put it on the outer aspect of the foot. So it acts as an everter. Okay. You can also consider a Dwyer's osteotomy. So you have open and closed, open wedge and closed wedge osteotomy. So basically, in open wedge osteotomy, what you do is the deformity is here. So you kind of make a wedge opening there and put a bone graft so that the curve is corrected. Otherwise, you can also remove a wedge from the other side and so that it becomes straightened. Okay. Some prefer a closed wedge osteotomy. So Dwyer's osteotomy is an open wedge osteotomy of the calcaneum. Okay. So just minimum age is 3 years. Then you have Dillwyn-Evans procedure. It consists of a PMSTR, so thorough soft tissue release PMSTR with calcaneocuboid wedge resection and fusion, so CC. So what do you do in DE is CC. So I like to remember it as CCDE. Okay. So calcaneocuboid wedge resection and fusion with PMSTR, Dillon-Evans. So what you do is you have the calcaneum here, you have the cuboid, take off the wedge. Okay. Then you try to correct the deformity. Next, you can also do a wedge tarsectomy. So what you can do is you can remove a wedge of bones from the mid-tarsal area. Okay. So once the wedge is removed, the foot can be brought to the normal plantigrade position. Then you can also do a triple arthrodesis. This consists of fusion of the 3 joints of the foot. So subtalar joint, calcaneocuboid, and talonavicular, TN, CC, and subtalar joints. Of the 3, the talonavicular fusion is the most difficult to achieve because, as I said, the talus is, it's going downwards and medially because of angulation of the neck. You can also go for Elizarov's technique. Okay, so you also have methods for maintenance of the correction. So you have CTEV splints. They are splints made of plastic. Okay, so they're molded in such a way that when they're tied with straps, it keeps the foot in the corrected position. So CTEV splints. Then Dennis Brown splint. So it is a DB splint or a foot abduction orthosis. Okay, so it holds the foot in the corrected position. It is used throughout the day before the child starts walking. Once the child starts walking, it is used at night, and CTEV shoes during the day. Okay, Dennis Brown at night, CTEV shoes during the day. So CTEV shoes are modified shoes. So it has a straight inner border. Okay, it has a slightly outward raise. Okay, and also it has no heel. Okay, so they're used till the child is 5 years old. Then this is the treatment plan. So first, examine to rule out neuromuscular causes. Try to rule out polio and AMC and all that. So if it is idiopathic clubfoot, if it is a fresh case presenting at birth, you've seen the dorsiflexion, you've done the screening test, okay, you've seen all the other features. So first, conservatively go for Ponseti method of serial casting for 2 to 3 weeks. And then if you want to still facilitate it, you can do a percutaneous stenotomy of the tendo Achilles. If there is a correction, again till 1.5 years, DB splint till the child starts walking, splint at night, and CTEV shoes during the day after 1.5 years, follow up till 10 to 12 years, and congratulations. And if it recurs, treat it as an old or neglected case. Okay, if it is not corrected till 4 to 6 months, okay, if all the deformities are left, PMSTR. If only equinus is left, do a posterior release. Only heel varus is left, do a Dwyer's osteotomy. So you do a limited soft tissue release. But if it is an old and neglected case, less than 3 years, go for soft tissue release. 4 to 8 years, Evans operation. Okay, 8 to 11 years, do a wedge tarsectomy. Okay, 12 years, triple arthrodesis, and already operated, so Elizarov's technique. So what is a plan of treatment? So most cases are treated early. They respond well to non-operative methods. So child who does not respond, so if there is resistant club feet, so they are severely deformed, they have associated AMC, etc. Child whose deformities have recurred, so it is recurrent. It happens if correction is not maintained. So the first deformity to recur is the equinus, CAVE, last corrected, first to recur. Child who has presented late or has not been adequately treated is neglected. So this is the flow chart.